أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والعاقبة للمتقين والصلاة والسلام على رسوله الكريم سيدنا محمد وآله وأصحابه أجمعين برحمتك يا أرحم الراحمين. All praise due to Allah, the Lord, Cherisher, Nourisher, Sustainer and Master of the universe, the most gracious, the most beneficent, the most merciful. Ya Allah, it is only you that we worship and it is your guidance that we seek. Ya Allah, keep us in the straight path. Ya Allah, shower us with your choice of blessings. Ya Allah, shower us with your mercy. Ya Allah, guide us. Greetings, salam, salutations on our beloved Nabi Muhammadur Rasulullah sallallahu alayhi wasallam. Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to Medical Files, brought to you by the Islamic Medical Association of South Africa and hosted by myself, Faizal MJ Suleman. We welcome our listeners on Radio Al Ansar, CII Radio, Voice of the Cape, Radio 786, Sirius FM, Radio Islam and IFM Port Elizabeth, and all listening to us on audio streaming and other platforms. Our topic for discussion this evening is diabetes, and our guest is Dr. Hoosen, Randeree, an endocrinologist and a diabetologist practicing at the Parklands Hospital in Durban. Dr. Randeree, Assalamu alaikum wa rahmatullahi wa barakatuh, and Jazakallah khair for joining me on the program this evening.
Wa alaikum salam wa rahmatullahi wa barakatuh.
Yeah, I think today, I should have said today is an extra sweet day, being World Diabetes Day, Dr. Randeree.
Absolutely.
Alhamdulillah. I did mention that the topic for discussion is diabetes. Let's just start off by discussing what is diabetes.
So diabetes is actually a disorder of metabolism, and a lot of people confuse it as only affecting glucose metabolism, but overall it also affects protein and fat metabolism. But by and large, what actually happens is because of either lack of adequate insulin secretion from the pancreas or lack of adequate action, we call that insulin resistance, both put together result in this metabolic disorder that we call diabetes.
Mm-hmm. Thank you. In fact, I got a very first WhatsApp message that's come through and says you haven't introduced Dr. Hoosen Randeree. Dr. Hoosen Randeree, I think, needs no introduction to the airwaves. And of course, Dr. Randeree is, as I say, a practicing physician, an endocrinologist, a diabetologist. He practices at the Parklands Hospital in Durban. And of course, I'm not going to go beyond that because time doesn't permit, Hoosen.
No, not at all. You can carry on.
But just for clarification, I said endocrinologist, diabetologist. What's it?
So basically, you know that endocrine system is involved with the study of the glandular system of the body. So diabetology is falls within the ambit of endocrinology. So, but most of what we see, of course, is diabetes. Of course, at the same time, we look after other endocrine disorders.
Now, what is the status of diabetes and its prevalence in the world today?
So it is estimated, like in 2021, there were the last figures, there were 537 million type 2 diabetics worldwide. And this is for the people in the age group 20 to 79. And it's interesting that we're facing this global epidemic or pandemic of type 2 diabetes. And this rising prevalence that we're seeing is not only confined to developed countries but also to developing countries, including Africa. And in fact, the prediction is that by the year 2030 there will be like something like 643 odd million type 2 diabetics. As it is, there's 1 in 10 people in the world are diabetic. So you can imagine that if this rise is going to continue as it has been doing, then we're going to be seeing many, many more type 2 diabetics worldwide. In fact, every time there's a prediction of this nature being made, that number gets surpassed well before the date arrives. So we really are facing a huge problem throughout the world.
And what age groups are affected mainly, Dr. Randeree?
Yeah, so it's generally a disorder of middle age, but what we're seeing throughout the world is that with possibly, and is one of the reasons, with the rising prevalence of obesity, we're seeing diabetics, especially type 2 diabetics, appearing at much earlier age. And we're now even seeing individuals in their 20s who are developing type 2 diabetes.
Now, you did mention world figures and give us some really exorbitant figures that are really mind-boggling. How is South Africa affected?
Well, as I pointed out earlier, being part of Africa, we also subject to the same rising prevalence. And in fact, in some stats essay estimated that there were something like almost 2 million type 2 diabetics in South Africa in 2011. When they next did their analysis in 2021, that had rose to almost 4 million. Mm-hmm. So you're looking at, quite a substantial increase even within our South African environment.
Now, you mentioned type 2 diabetes, I think, once or twice while we were discussing. How many types of diabetes are there, and what's the difference between the different types?
Yeah, so there have been different classifications, but for broadly speaking, we have type 1 diabetes, which is usually one that occurs in younger individuals, and it is due to what we call an absolute deficiency of insulin. And for those patients, they need to go on to insulin from the time their diagnosis is made. And the more common type of diabetes, in fact, far more common than type 1 diabetes, is type 2 diabetes, which is the common variety that we see in people, for example, who have a family history of diabetes, who are overweight. And these individuals form the large majority of the diabetics in the population.
Mm-hmm. Now, we often hear the word pre-diabetic. What is pre-diabetic, and how does one deal with that?
It's a very interesting comment you ask about pre-diabetes, because there's, of course, normal glucose tolerance, which is a normal individual, and then there's diabetes. And if you have glucose levels between those ranges, in other words, between normal and diabetes, is called pre-diabetes. And generally, for absolute terms, you have to define that by a glycemic target. In other words, you have to define it by either a glucose tolerance test, or by what we often use in terms of control of diabetes, the HbA1c, or glycosylated hemoglobin. If it falls between a certain range, between 6 and 6.4, then you consider it to be pre-diabetic. Now, one thing I just want to remind audience as well about is, a lot of people talk about, touch of diabetes, etc. There is no such thing as a touch of diabetes. An individual is either diabetic or not diabetic, or it could be that they have what we call, as you point out, pre-diabetes. Now, pre-diabetes carries with it a potential for future development of diabetes. So it doesn't mean you do nothing about pre-diabetes, because if you're able to get an individual with pre-diabetes to lose weight, to change their lifestyle, to start exercise, you can alter that trajectory towards diabetes. You may not be successful in all individuals, but you certainly can halt the progression in individuals by putting into place lifestyle changes. Also, there are certain drugs that can be used and have been shown in clinical studies to prevent the onset of diabetes in people who are pre-diabetic.
Thank you for that, Dr. Randeree. You're listening to Medical Files, brought to you by the Islamic Medical Association of South Africa and hosted by myself, Faizal M.J. Suleman. Our topic for discussion is diabetes, and our guest this evening is Dr. Hoosen Randeree, an endocrinologist and a diabetologist practicing at the Parklands Hospital in Durban. Remember that doctors and guests on the Medical Files program will help you with any medical problems that you pose by giving you advice on air. However, they do not have your full medical history and have not examined you. Please verify the advice given to you on air with your regular doctor who knows your medical history, allergies, etc. Neither the doctors nor the relevant stations nor the Islamic Medical Association of South Africa will take any responsibility for any adverse reaction caused by the advice given on Medical Files. Remember also that this is an interactive program, and if you have any questions on diabetes, you may forward same to us on 060 904 1056. Dr. Randeree, prior to the ad break, I did mention that maybe you can discuss with us some of the symptoms of diabetes, and at the same time, how does one diagnose diabetes?
Yeah. So the classic symptoms that we talk about is usually excessive thirst, passing a lot of urine, and in fact weight loss is one common symptom. But I think I need to remind the audience and the listeners as well that it can present in many non-specific ways as well. Some people will just come in with fatigue. Others will come with, besides tiredness, with general feeling of ill health, dizziness. So it can be very non-specific in the symptoms. The other thing that sometimes happens is, if they don't come with classic symptoms, is patients then sometimes present with a complication that alerts the practitioner to the diagnosis. So, for example, they will have a leg ulcer, for example, that's not healing, or they would have presented with a coronary event like a heart attack or a stroke. Others may come with recurrent infections. So you often find that you're picking up diabetes now when the person has a complication of diabetes. And it's very interesting that as much as we talk about the number of diabetics that are around or within a certain country or society, you'll find that almost half of the people who have diabetes are actually undiagnosed. So there are a lot of people walking around who don't know they have diabetes. And because the symptoms are subtle, they may attribute it to stress or to other factors. So it's important that you have a high index of suspicion, especially in population groups in which diabetes is common, for example, the Asian population in this country.
Are there any preventative measures one can take? Since many of us are walking around with it not knowing.
Yeah. On a community level, the most important thing is a healthy lifestyle. And especially if you have a family history of diabetes, it's imperative that you eat correctly, that you exercise regularly, and especially you avoid obesity, in fact, becoming overweight. So those are very important, and they are practical ways of preventing yourself from becoming diabetic. And of course, if you have a family history, then clearly you need to periodically have yourself checked out for whether you have developed diabetes or not.
You mentioned obesity. Is obesity one of the main causes of diabetes?
Absolutely, because it is suggested that this high prevalence that I spoke about globally of type 2 diabetes, often people argue that is actually in parallel to the worldwide epidemic of obesity that we have. So if, for example, you are genetically predisposed to develop diabetes because you got a family history, if you allow yourself to gain weight or become obese, that is what we call an environmental precipitant to the development of diabetes. So that's why it's so important to keep the weight down.
And a diagnosis, how does one diagnose it currently?
So usually in the presence of symptoms, if you do a blood sugar level and it's above a certain level, you can diagnose diabetes. And in other words, that's a symptomatic patient. You can also use what we call the 3-month glucose average. And if it's above 6.5%, that's the HbA1c, that diagnoses diabetes. The problem arises when you have asymptomatic individuals. In other words, the person has got no symptoms of diabetes. In that case, you then have to diagnose it with a laboratory test. And the laboratory test that we use is either a glucose tolerance test or, as I pointed out earlier, the 3-month glucose average, which is now included in the diagnostic criteria for diabetes.
We often hear of people saying, you must manage your diabetes. Now, type 2 is about most common that as you mentioned. Yeah. How does one manage type 2 diabetes?
So we go back to basics. In everything in medicine, non-pharmacological or lifestyle measures is the most important thing. So clearly you got to now maintain a healthy lifestyle and keep your weight down. You got to exercise. You got to follow a diabetic diet with the adequate advice from a dietitian. And so that's the foundation or the backbone of therapy. After that, of course, it means then now you have to choose an agent or a pharmacological agent to treat the diabetes. And today, unless you have a contraindication or you're intolerant to it, the backbone of therapy is indeed the commonly used drug metformin. Often is the first line therapy for type 2 diabetes.
In fact, speaking of metformin, there's a question that's come through. Assalamu alaikum. I am 71 and a diabetic. I take metformin once a day. What is the normal reading? Jazakallah khair.
Jazakallah for that question. Basically, we have to bear in mind that when we deal with the older individual, we must be careful that we don't get too dramatic in terms of control. So we accept much or higher levels or somewhat higher levels of blood glucose as well as the 3-month glucose average. So if that individual has a glucose of around 7 to 8 millimoles per liter, if they're testing and their HbA1c, which is a 3-month average, is around 7% or even a little higher, we are quite okay in accepting that. We've come to realize that if you're dealing with a young individual who's just recently diagnosed, who's got no other comorbidities, who's got a long life expectancy, etc., then we aim for much tighter control because we know that that will impact in the long term. But the older you get, then, and especially when there are other factors, in particular we worry about in the older individual, the risk of what we call hypoglycemia or a low blood sugar. So that's what you need to definitely avoid. And if in this individual is on one metformin a day and has finding glucose levels of between 6 and 8 and has got an HbA1c, which is a 3-month average of between 7 and 7.5%, that's actually quite acceptable. Although internationally, the target we aim for is under 7% across the board in diabetics.
060-904-1056. 060-904-1056. Any questions on diabetes, please forward them to us via WhatsApp, and Dr. Hoosen Randeree will, inshallah, attempt to answer those questions. Now, Dr. Randeree, you mentioned metformin. Now, we always heard that metformin can harm the kidneys. Is that true?
So that's a very, very common misconception that lies in the minds of the public as well as patients. Now, there is no evidence that metformin harms the kidney. Mm-hmm. And people get confused with the fact that metformin is, and especially if you look at it, it seems a paradox. If it was harming the kidney, then every individual who's diagnosed with type 2 diabetes throughout the world will today end up in kidney failure. So there is no evidence. Mm-hmm. The point that is mistaken is usually the fact that if an individual, for whatever reason, starts to develop chronic kidney problems, then what we call the GFR, which is an index of their renal function, starts to decline, then at a certain level, metformin dose has to be reduced. And below a certain cutoff, usually a GFR under 30, we recommend people to stop metformin, not because it's harming the kidney, but because in the context of poor renal function, there is a risk of a complication called lactic acidosis. Mm-hmm. So it's not that the metformin is harming you, it's just that at a certain level of kidney dysfunction, like with other drugs, you often find that as your kidney function deteriorates, you have to modify the dose of many medications. Mm-hmm. So if you have to modify that's exactly what you have to do with metformin. And there's no evidence that metformin itself harms the kidney.
Mm-hmm. There's another question that's come through. Assalamu alaikum. Is it true that if you're on metformin, you need to take B12 supplements? Jazakallah.
So that's an important question. There is no doubt that, firstly, B12 deficiency itself is common in the community, so we have to bear that in mind. Mm-hmm. Secondly, there is evidence that in the people with long-term metformin use, especially in the elderly, one finds that B12 absorption is affected by metformin. So yes, it's not routine to have to take B12 supplements if you're on metformin, but yes, it's important that you periodically check B12 levels in people who are on metformin for a long period, and if it is low, then you need to treat that. So in other words, it's not that you should be make it a norm that everyone who is on metformin needs to take B12.
Mm-hmm. Now, many patients that are on that suffer from type 2 diabetes are on insulin. Why is it that some of the patients are on insulin?
So as I told you earlier, type 1 diabetics are on insulin from the beginning because they have a complete lack of insulin or near total lack of insulin in the body because the pancreas is destroyed by whatever process. Now, when it comes to type 2 diabetes, bear in mind that this is a progressive disease. It is estimated that, for example, when you first diagnose type 2 diabetes, about half your pancreatic beta cell function, the pancreas that produces insulin, is already lost. And then over a period of years, you lose maybe on the average 5 to 10% per annum. So you can understand that initially, while there is enough pancreatic secretory capacity for insulin, you can use drugs that stimulate insulin secretion. But because of this progressive nature of type 2 diabetes, there may come a time in the life of a type 2 diabetic where the tablets stop working because now there's just not enough insulin secretory capacity, and that's when one needs to consider, or very often patients then need to be started on an injectable therapy such as insulin.
Mm-hmm. Now, everyone speaks about these newer therapies for type 2 diabetes. Can you talk about some of these agents, Dr. Randeree?
So, it's important to define what we mean by old and new, because many of them are around already for a couple of years. But traditionally, we've had metformin, which we've spoken about, and that's the drug that makes our insulin work in action, and it improves insulin action. And then we have had a category of drugs called the sulfonylureas, which stimulate insulin production from the pancreas. And these two, together with insulin, had been the only available therapies for many years for type 2 diabetes. Of course, along the way, there were drugs that emerged that we call them the meglitinides, and they stimulated insulin production. There were one or two drugs that reduced glucose absorption, but these are not very popular in use at the moment. So the backbone was the sulfonylurea, then came, and metformin, and then came another class of agents called the DPP4 inhibitors. People talk about Jalra or Galvus, Januvia. These are other drugs also. They've been around for a while. The advantage is that they do not drop the blood sugar below normal. So those had been around for quite a few years. In recent times, two new classes of agents have emerged. One of them is called the SGLT2 inhibitors. Now, these drugs, they act quite differently from the other drugs that I mentioned. What they do is they cause glucose to go into the urine. So you actually cause, it's called like glucose down the drain. So they prevent the reabsorption of glucose in the kidney, and so the glucose just passes into the urine. And that's one class. And there's a second class of drugs called the GLP-1 receptor agonists. Now, these have become very popular because these are the injectable drugs which are associated with a degree of weight loss together with improvement in glucose control. And these two classes of agents, I need to emphasize something about them. Today, they not only are around for the purpose of bringing the glucose down, but they afford protection in two major organ systems in our body. One is the heart, and two is the kidney. So whereas previous drugs were able to bring the sugar down, they did not afford any particular benefit in the prevention of cardiovascular disease or in people with kidney disease. So these drugs now clearly have a very important role to play, especially in people with established cardiac disease or otherwise who have any evidence of either heart failure or chronic kidney disease. In fact, the SGLT2 inhibitor class that I talked about, which cause glucose to go into the urine, they have been game changers in the treatment of chronic kidney disease in diabetics.
So when one has diabetes, which of one's organs are affected?
So basically, we can look at it broadly. Diabetes can affect many organs in the body, but we talk about two types of complications. One is what we call microvascular, small vessel damage. And in that respect, we talk about the eyes, the kidneys, and the nerves. And that's why we recommend that diabetics, for example, should go periodically to the ophthalmologist to look for diabetic eye damage. It's not an optometric test for visual acuity, although some optometrists can screen for eye damage, but we're looking for what is called retinopathy, which is eye damage from diabetes. The second is kidney damage that I mentioned to you, and that we detect very early on by measuring protein excretion in the urine, right, as well as by doing a blood test, which I alluded to earlier, which is the GFR or glomerular filtration rate. And the third thing is nerve damage. And nerve damage, patients who have diabetic neuropathy, as they call it, complain of burning, pins and needles, pain in their feet, and they have abnormal sensation. So that's small vessel disease, right? Large vessel disease is another big category. And that is now when we talk about people developing heart attacks, people developing strokes, as well as occlusion of their peripheral vessels, which often results in gangrene and often can lead to amputation. So we talk about microvascular, with small vessel, and we talk about macrovascular or large vessel disease. Over and above that, there are many other things that are associated with diabetes, including, as I said earlier, propensity to infection. There are a whole host of musculoskeletal abnormalities that people develop. But the main ones in terms of vascular complications are the ones we need to be looking out for.
Mm-hmm. And can diabetes be reversed?
It's a very important question. Because people ask that, can I cure my diabetes? I don't think there's much evidence that you can completely cure diabetes, although the studies that have emerged, as you know, one of the modalities of treating overweight or obese individuals is, for example, with bariatric surgery. People go for bypass surgery.
Yes.
And what has happened in those where there's a significant amount of weight loss, what has happened is many of these individuals have gone into what we call diabetes remission. Mm-hmm. Okay, so that then by that we mean that your HbA, once your glucose average is under 6.5%, having stopped all form of therapy. But people argue as to whether that really means that you are cured. It actually has gone into remission, and there's studies that show that over a period of time that diabetes may re-emerge. I say that also because besides bariatric surgery, in the horizon are other drugs in that class that I spoke about, the injectable drugs, the GLP-1, and there's also GLP-1 plus GIP agonists, where you will find that they are able to produce significant amounts of weight loss to the extent that diabetics, for example, on insulin can be controlled only on tablets. And some of those have actually been able to come completely off therapy. That's the function of the magnitude of the weight loss as well as the other effects that these drugs have. So I think in the horizon, there may well be in the future one of the aims of therapy is not only to control glucose, but also to possibly induce remission. The problem is you have to stay on the drug in many instances to maintain yourself for long-term remission.
You listen to Medical Files. We're discussing diabetes, and our guest this evening is Dr. Hoosen Randeree. Dr. Randeree, questions are pouring in. One of the questions is, Salams, what is the best way to check if you are diabetic? My one doctor told me I'm borderline and no need to start the meds. Yet another doctor told me I need to take the meds. I'm so confused.
Yeah, okay. So earlier on, that whole story about borderline, I think sometimes people are diabetic and they say, I'm borderline because they feel the sugar levels are not high. As I say, you're either diabetic or you're not diabetic or you are pre-diabetic, which is in between. And you only really can diagnose pre-diabetes by doing some measure of glucose tolerance or intolerance, and that's where you can use the glucose tolerance test or you can use the 3-month glucose average. Having said that, as I pointed out earlier, there is some evidence in the literature that apart from lifestyle for pre-diabetes or borderline, and we don't like the word borderline, it's actually pre-diabetes, then there's some evidence that drugs like metformin, there have been studies to show, amongst other drugs, that if you use it, you may be able to prevent the future development of diabetes. And the doctor usually weighs up the options and puts it to the patient and says, listen, you have an option of lifestyle alone, or you got the option of lifestyle plus a drug like metformin.
Mm-hmm. The next question that comes in is, you speak of metformin. Assalamu alaikum. In Ramadan, when is the best time to take metformin? Is it after iftar or during sehri? Jazakallah khair. But before you answer that, Dr. Randeree, let's just deal with Ramadan fasting. I mean, I know it's 3 months before Ramadan, but I think now's the time for us to prepare.
Yeah, I think with Ramadan coming earlier and earlier, each this time we're going to start early in March, inshallah, in next year. I think what the patient out there need to remember is that they should start engaging their practitioner or their doctors from early on, because as you know, it is recommended that anything between 6 weeks to 3 months before Ramadan begins, that you schedule an appointment with your doctor to go through many aspects, including the quality of your glucose control, the screening for complications, plus getting the advice on how to manage your diet and physical activity, as well as the adjustments to treatment that you need to make in Ramadan plus the frequency and the timing of your glucose testing. So all of that, it's no point getting all of this done on the doorstep of Ramadan. You've got to do that now, because you must remember the doctor will then be able to risk stratify the individual and then advise one whether they should or should not fast. Ultimately, the decision rests with the patient, but I think based on medical guidance, including what is being agreed upon by even Islamic scholars, there are certain categories of people who we would recommend they should not fast, especially if they've got significant complications from their diabetes.
And I'm sure that the doctor that you visit will confirm whether you should take your metformin after iftar or take it during...
No, yes, absolutely. But just to answer that question, metformin is a drug on its own that's not associated with usually with a tendency to drop the blood glucose. So if you're taking metformin twice a day, then you take it normally at sehri and at iftar. If you're taking it, if you have a slow release preparation like some people take, called the XR, then you take that at iftar. So and generally in Ramadan you always take the higher dose in the evening. So but to recap, you can take, if you're taking 1 and 1, you can continue taking that. If you're taking higher dose in the morning, you switch that to the evening. And in particular, if you're taking a slow release tablet, it is better to take it at iftar time.
Assalamu alaikum. I am diabetic in my 70s. However, I do not lose weight, but I gain weight. I'm concerned. Jazakallah khair.
So there's a natural, there may be many reasons for weight gain at that age, including comorbid conditions. Generally, people become less active, etc. The point is that the weight loss that we're talking about with diabetes is due to uncontrolled diabetes. So perhaps this individual, the diabetes is controlled, but there are other reasons why they've been gaining weight, including the possibility of inactivity. There may be, as we grow older, there may be something like a thyroid disease to look for. But certainly it implies in effect that the diabetes is generally well controlled.
Jazakallah khair. Say, Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakallah for an informative topic. Doc, recently Ozempic is the buzzword used for diabetes. Like gold, as most people are also responsible using this for weight loss. Please advise, if not diabetic, what are the repercussions of taking this? With regards to metformin, it is contraindicated with renal failure patients. My husband has polycystic kidney disease. He was put on this when he was diagnosed with polycystic kidney disease as secondary prevention. Once his eGFR dropped to 26, his doctor stopped metformin. He is now on dialysis and not on any oral medication. I've also heard metformin causes weight loss. I've heard Foxigar and Jardiance are cardioprotectors. Is this true, and how important is compliance? Can Lyrica be taken for neuropathy, burning, tingly feeling under the feet? Jazakallah khair. Now there's a whole host of questions. I don't know how you're going to unpack
Okay,
that.
just very quickly. Let's just first get, Lyrica or pregabalin as they call it, is can be taken for one of the drugs used for diabetic peripheral neuropathy. Just to bear in mind also, we alluded earlier to B12 deficiency. Bear in mind that it's always important to check B12 levels, because they can have symptoms of peripheral neuropathy as well, and you may well benefit the patient by giving them B12 as well. So that's the first thing. The other question, I'm working backwards, is that things like Foxiga or Jardiance, yes, as I pointed out earlier, they are not only kidney protective or renal protective, they are also cardioprotective drugs, especially empagliflozin, which is Jardiance, which comes out to have benefits in many sort of cardiovascular outcome trials, including heart failure trials. These drugs are really beneficial. Okay, that's the second point. The third one is, yes, the doctor was right to have stopped the metformin once the GFR was under 30. Many patients with chronic renal failure, because they often end up having not to need any medication, for their diabetes. So that's not unusual. And also there you have to be particularly careful about low blood glucose, because you have to be careful, because whatever drug you take tends to last longer in the system. It doesn't get cleared by the kidneys not functioning. So yes, avoid low glucose. And if your HbA1c is respectable without treatment, many patients on dialysis do not need any formal treatment. If they do need it, there can be certain drugs that can be used, including insulin. The buzzword about Ozempic, yes, it's like gold in the community at the moment, because yes, it is true that many people are using it for pure weight loss. Now, there's always the statement, I'm not, as a diabetic, getting Ozempic because everybody is wanting it to, using it up for weight loss. But the truth of the matter is that even at higher doses, the drug is registered in many parts of the world as a weight loss drug. So yes, these are important drugs that have come on. I agree that many of the individuals are using it injudiciously for cosmetic purposes rather than having an absolute indication. But I think the degree of weight loss we see is not as dramatic and robust as I pointed out to you for some of the drugs that are still going to come down the line. The combination agonists, where the magnitude of weight loss goes to 10-15% of a person's body weight. So yes, it is. They are used at higher doses for weight loss, and they are certainly used at somewhat lower doses also for diabetic control. Problem is, globally there's a shortage of the drug, and today, one of the biggest challenges is there are patients who are diabetic who may well benefit from this class of drug, but who can't access it because of the shortage.
Salams, I'm a patient of Dr. Randeree for the past 15 years. May Allah subhanahu wa ta'ala reward him for taking such good care of the well-being of his patients. Lifestyle changes and a good diet assisted me with diabetes. Mumtaz Khan. Jazakallah khair for that.
Ameen.
70 years old. My fasting blood glucose is elevated to around 6.8 in the morning, is normal around 5.7 before lunch and before dinner, and HbA1c 6.2. So the morning glucose is only elevated, and before lunch and before evening blood sugar are normal, and I'm not only in treatment. Is this the dawn phenomenon? Does this morning only elevated blood glucose require treatment with drugs, assuming a person cannot do much more to change lifestyle?
Okay. So I think the first important thing is I'm not certain whether they're diabetic or not, because none of those levels, like the average 6.2%, doesn't define diabetes, and the other levels don't. But I'm assuming that this person is diabetic and is faced with the challenge of having a high morning glucose. They allude to an important thing. It's called the dawn phenomenon. In preparation for the day, many hormones, including growth hormone, cortisol, adrenaline, and all of these hormones, what they do is they cause a rise in the blood sugar. So you'll find an individual, say example, they get up at Fajr time, say close to 4:30 or 5, they'll do a blood glucose. That blood glucose is pretty normal. Then they won't have anything to eat, and then next test their sugar at about 7 o'clock before getting up to get to work. You will find that will be higher, with them having not had a morsel of food or have drunk anything in that period. So this is that dawn phenomenon. My own feeling is it's a very difficult phenomenon to treat, especially because whatever you give the night before carries the risk of dropping the sugar at 5 o'clock in the morning. I tend to tell individuals not to chase the dawn phenomenon, and invariably it does not impact significantly on glucose control. It's just a physiological phenomenon that you got to deal with, and as I say, not to become too worried about it.
Dr. Salams, Doctor, I am 67 years old. My glucose level is 5.1 to 6.8. Thirsty early in the morning. What do you recommend? Jazakallah.
So many individuals would think that they have thirst when they are sleeping at night. They find their mouth becomes parched, etc. At those levels of blood glucose, the blood sugar is not the cause of the dryness of the mouth, and you've got to look for other causes. One of the most common things I find in practice is people who have, for example, obstructive sleep apnea. You've heard of. Others have got they mouth breathe. So what happens is that instead of breathing through their nose, they breathe through their mouth. So their mouth at night becomes parched, and all it takes is a little bit of water just to moisten the tongue and to quench that bit of thirst that they have. That's one possibility, and very common possibility. And the other one that sometimes people find is that they're on certain drugs, we call them anticholinergics, especially when they are for example, have urinary problems, urinary incontinence, they take these tablets in order to control that irritable bladder. And you often find that they will also complain of a dry mouth or, at night. But those levels of blood sugar are not contributing to those symptoms.
Doctor, the next question I don't think is diabetic related, but I'm sure you know better. Salams, doctor, I am gaining weight and want to find out what I can do and what are the symptoms of PCOS, and how will I treat it? I do have skin tags, hair growth on chin, under, and irregular periods. I'm not sure if that's diabetes.
No, basically it's a separate subject, but I mean he's referring to polycystic ovarian syndrome, which manifests with weight gain, irregular cycles, and other manifestations of excess androgens in the body, for example hair growth and acne. And I think that's what is diagnosed, and once diagnosed there's lifestyle changes to put into place. Metformin or glucophage has been used, and depending on what the dominant symptoms, especially if there's excess hair growth or acne, then there are other drugs, including certain pill combinations, as well as the other drugs like spironolactone that can be used to control that. That's a completely different. Hopefully, inshallah, in the future, we can dedicate a program to that.
Jazakallah khair. Doctor, the next question, what causes low iron? Diabetic related?
No, diabetes is not a cause of low iron. In a whole variety of causes. It may be due to dietary intake that's not adequate. The other times, most commonly in females, for example, is due to excessive menstrual blood loss. And then in males in particular, you must always worry about iron deficiency being caused by some form of gastrointestinal blood loss. So that to the extent that if you find a male that has got iron deficiency, that individual in particular warrants gastrointestinal investigations to exclude a lesion from which they could be bleeding in the gut.
Now, if a person is diabetic, what are complications that are associated with diabetes, and how does one screen for these?
So I touched on it earlier. We talked about the microvascular and then the macrovascular complications. And so, as I said, for the eyes, you see the ophthalmologist to look for the kidney, you look for protein, and you look the GFR, and for the nerves, it's just usually an examination, neurological examination of the legs to determine whether there's absence of proprioception or vibration or touch, etc. These are all the signs of diabetic peripheral neuropathy. And then for large vessel disease, and I think that's important, not everyone who's diabetic now needs to go and have an angiogram done. But what is important is good glucose control, and more importantly with it, do not forget other of the risk factors that are associated with vascular disease. Meaning, you have to lose weight, you exercise, you don't smoke, and very importantly, control of blood pressure as well as control of your cholesterol level. You have to use all of those sort of comorbidities and bring them into focus and control those conditions if you want to prevent yourself from getting a heart attack, a stroke, or peripheral vascular disease.
Okay, in 30 seconds, I need you to answer one more question, doctor. I am diabetic. Assalamu alaikum. I'm diabetic, but I'm not sure if it's related to my continuous heavy head, like pins and needles in the front and middle of my head. It has moments where it's constant throughout the day.
I think the question is, could this be a diabetic complication or a diabetic related symptom? Not usually. Those symptoms that I describe are usually in the peripheral nerves that I alluded to.
Dr. Randeree, Jazakallah khair for joining me in the program. Unfortunately, time's up. We've got like a minute for me to ask you for your final message to our listeners.
I think it's important that, they say, know your numbers. And I think that it's imperative that patients take control of the disease, right? And very importantly, I think that you don't fear the complication as long as you take measures to lead a healthy lifestyle, to exercise, to comply with medication. Very important to be adherent to your medication. Go regular for your checkups to your doctor so that they can screen for complications and establish good control of not only blood glucose but all your blood pressure and your cholesterol. Inshallah, with that type of approach, you could prevent yourself from getting complications.
Dr. Hoosen, Randeree, again, Jazakallah khair for joining me in the program. May Allah SWT reward you for your sacrifices and for having shared that information with us.
Jazakallah khair.
Time for me to bid you farewell. I want to thank all the engineers at the various radio stations for the sterling piece of work done. And Jazakallah khair for having tuned into Medical Files. From myself, Faizal MJ Suleman. Assalamu alaikum wa rahmatullahi wa barakatuh.